Hi, welcome to considerations for dysphagia management in strokes. Upwards of 50% of stroke survivors will suffer from dysphagia within those first few weeks, with about 15% continuing to have dysphagia for at least 6 months post-stroke. A complication of dysphagia is aspiration pneumonia. So as speech therapists, we are looking to balance preventing aspiration pneumonia while also helping the patient maintain adequate nutrition and hydration, as 40% of dysphasics who have survived a stroke in inpatient rehab facilities suffer from malnutrition and or dehydration. So we really want to be preventing that as our patients are healing and working to get their strength back to go home. So some things that we keep in mind are that patients who are dependent on feeding, so people feeding them, who have poor oral care and are aspirating solids are at higher risk for developing aspiration pneumonia. So as non-speech therapists, what you can do to help keep our patients safe is when you notice signs and symptoms of them aspirating, take note of what perhaps they were coughing or choking on. Was it a solid? Was it a liquid? Perhaps it was both. Was someone feeding that patient? Were they in poor positioning, slumped over, laying down, or maybe they were distracted, maybe they were talking while they were eating or watching TV. So taking into account what was happening in the environment when going to inform the nurse or the doctor, who could then put in a referral for the speech therapist to do a bedside evaluation. And from there, we might perform a modified barium swallow, which is the best way for us to rule out aspiration and why they're aspirating.
So we're, like Elizabeth was saying, we're really looking at doing a modified barium swallow study because it helps us determine if the patient's actually having instances of aspiration and penetration. And if so, on what food or liquid consistencies is that occurring? Are there any compensatory techniques that the person can utilize during meals to eliminate or reduce those instances? And then of course, are there any swallowing exercises that we can be doing with that patient to rehabilitate maybe the muscles that are not as strong or working as properly? When we're making diet recommendations, especially if we're recommending a modified food or liquid consistency, we're really trying to take into account the whole patient and the person as a whole. So there's been a lot of research that has shown that the modified food consistencies, especially like your nectar and your honey thick liquids, your pureed solids, they contain so much less caloric value, nutritional value than your regular liquids, your regular foods. A lot of the thicker liquids like your honey and your nectar are made with high fructose corn syrup, cornstarch products, which leaves the patient feeling very full. It doesn't give them as much nutritional value. And this is so important because your patients that are coming to rehab are already weak. They're already coming in with multiple comorbidities. And now we might be recommending or asking them to eat and drink foods and liquids that may not be as nutritious to them. That we also take into account patients' overall energy level that they have from a day to day. So there is this theory, it's called the spoon theory. And it's the idea that each spoon represents a certain amount of energy level that the patient has. And the patient might come to rehab and have 10 spoons for the day. And physical therapy or occupational therapy might come in and ask the patient to do a session with them, get them out of bed, bring them down to the gym. And that might take 3 of their spoons for the day. And the nursing comes and they might have to do nursing care, and that takes, more of their spoons away for the day. Now they're only left with a few, and then dinner time rolls around and speech might have recommended this modified food consistency, this compensatory strategy. Maybe they need some assistance while they're eating, and that just kind of depletes them of their energy for the whole day. So we do take a look at the whole person and not just everything through a single lens. Elizabeth is actually going to show you a video of a modified barium swallow study and what an abnormal versus normal swallow looks like.
So on the left, we have a normal swallow where we're going to see the material go down their esophagus the correct way. And then on the right, we have the abnormal swallow where we're going to see the food and liquid go down the wrong way, down their trachea and down into their lungs. And in this video, it doesn't look like the patient's reacting to the aspiration. And that's why it's so important to do this imaging, because the patient might not be coughing as a sign of their aspiration, and we can't tell that at bedside. And it's the same for compensatory strategies. We don't know if a chin tuck or a head turn's working, so we really need this imaging to help us make the best decisions.